Today, it's my pleasure to introduce Mami Taniuchi for the guest lecture as a part of her Expeditions bi-weekly seminar series. Mami, thanks a lot for accepting our invitation. Let me briefly introduce you and your work. Mami did her BSc in Biomedical Engineering from the Duke University and MS and PhD from BME here at the University of Virginia. She's an associate professor of medicine with primary appointment in the Division of Infectious Diseases and International Health at School of Medicine at UVA, and also has academic appointments in BME and the Systems and Environmental Engineering Department at UVA. Her primary focus and expertise are in developing and implementing molecular diagnostic assays to detect multiple pathogens, including poliovirus, SARS-CoV-2, and other enteric pathogens from clinical and environmental samples in low-resource setting, and implementing environmental surveillance for infectious diseases in low middle-income countries, training and mentoring researchers at overseas field sites. She travels extensively to work for prolonged periods at culturally and geographically diverse field sites to build capacity at collaborating institutions in Bangladesh, India, Pakistan, Tanzania, Thailand, and works with numerous collaborators at international and US institutions. Mami, thank you very much for accepting our invitation. I know Mami for a while now, and I've heard her talk and her remarkable contributions to science, especially in Bangladesh, Pakistan, and India. So without further ado, we look forward to your talk, Mami.
Thank you, Mata, for your kind introduction. Today, I'd like to talk about the environmental surveillance for SARS-CoV-2 and other pathogens that we're currently doing in Dhaka, Bangladesh for public health impact. And we put the public health impact there because this is a highly collaborative project, which we have worked very closely with the government of Bangladesh. And we actually report to them on a weekly basis to their national COVID task force. So this has been really a project where we've worked very closely with the public health stakeholders. So one of the leading public stakeholders that we work with is the Institute of Epidemiology and Disease Control Research. And it's like the CDC in Bangladesh. And so we work with them on a weekly basis. We also work with some epi modelers out of Imperial College London, and the work is mostly carried out at the International Center for Diarrheal Disease Research, Bangladesh, where I've been working for the last 15 years. Pictured here to the left bottom is a typical wastewater site where we actually get our samples. And then to the right, you can see one of our research investigators from ICDDRB, along with Aaron Whetstone and Neng Folwat, who actually work here at UVA with me, and they're actually in Bangladesh in that picture. So just starting off, just to give you a broad picture of the COVID-19 situation in Bangladesh. Bangladesh was the second most affected COVID-19 country in South Asia after India. We've only had about 2 million cases reported in Bangladesh compared to 44 million in India. So in terms of cases per million, the population, it was 3 to 5 times lower in Bangladesh. And we know 100% for sure that this is due to underreporting. And one of the reasons why there is so much underreporting was that there was very limited access to testing in Bangladesh because people were charged to be tested since July 2020. And so many people could not actually afford to get tested. Vaccination started in early 2021. And as of now, I think 72.8% have had 2 doses. I think this is actually now up to about 75% as of today. And one of the characteristics of Dhaka city is it's a mega city, and the population density is extremely high. It's about 30,000 people per kilometer squared. So some of the research questions that we asked ourselves when we started this work was, can we detect SARS-CoV-2, and will that detection tell us anything about the community transmission of that disease? And we also wanted to know, is there a difference in burden across the different geographical sites that we had throughout the city? And lastly, we also wanted to understand if we did genetic sequencing of the sewage, would it provide us this extra layer of information about emergence and spread of certain variants of concern. So one of the first activities that we undertake is actually tracing of the sewage. So Dhaka sewage network, unlike in high-income countries, is mostly informal. And what that means, it's that we have main pipeline that is actually a formal sewage line. And we have a series of all these small canals and ditches that connect to that main line, which has never been mapped. And so one of the first things that we needed to understand was who is contributing to which line and how is it connected to the formal system. And so we undertake this activity called blue line tracing, which is pretty much like mapping of these informal lines. And what that entails is one of our research officer goes out to the field with a physical map, and you have a highlighter, and you actually highlight even the ditches that run right in front of houses up to these larger open canals that carry sewage in and out of our study area. And once that's done, MD Ohid al-Islam, pictured here, collects all of these maps, and then he'll sit down and actually digitize all of these lines and then connect them all together to come up with a comprehensive map of this sewage network. And then if you look to the right, the darker green lines are the digitized sewage network. So this activity is quite laborious, you can imagine, and does take a huge team to go out every day to accomplish this activity. But once this is accomplished, we usually send the digitized sewage network lines to a company called Novelty, and they make these interactive maps, which you can see to the right, which is actually available to the public and can be found at the address shown here. And what you see in this particular map is our Ward 8 and 9 and 10 study area. And you can see that the borders of the wards are in that red and white line. And then you see the digitized lines in the darker green. And this interactive map actually allows us to drop a pin, which is the yellow diamond that you find here. If you drop it there, which means this is the site that you may want to sample from, then this interactive map will tell you how many estimated population of people are contributing to that particular site. And it will also outline in that lighter green the area, which is the catchment area that's included from sampling that one particular site. And so from about June 2019, which is prior to the pandemic, we had 12 sites in the middle income area, shown here, actually 8, 9, and 10. And what we were doing was we had a sewage surveillance system for multi-pathogens, and we were trying to look at upwards of about 40 pathogens, including Sabin viruses, which is part of the oral polio vaccine. Once the pandemic hit, we realized that could we potentially build upon the sites that we already have to look at SARS-CoV-2. And in fact, we were able to find SARS-CoV-2 quite earlier on in the pandemic in March. And we were able to secure more funding and open 33 sites around June 2020. So you can see them here, pictured here. And all the way to the left is the middle income area, which we had already mapped and had started the ES work back in June 2019. In the center, wards 2, 3, and 5 are the wards that include low income participants. And then all the way to the right, you see wards 19 and 18. Those are the high income areas. And currently, we've been doing this since March 2020. Currently, we actually have 51 sites across the Dhaka city. That includes the southern part of the city now. Again, just to reiterate, the Mirpur wards 2, 3, and 5 are the low income. Mirpur wards 8, 9, and 10, pictured all the way to the left top, is the middle income area. High income areas could be found all the way to the right top. And then the southern Dhaka area are a mixture of low and middle income area. The ward population varies quite a lot, from about 50,000 to 150,000. Our estimated catchment population per site varies from 1,000 to 600,000. And the estimated catchment area per population, again, is different depending on each catchment site from about 0.04 to 7.01 square kilometers. And these are example sites that we have, and you can see that it depends on like where we are in our study area, but many of our study areas have these open canals where a whole bunch of other smaller ditches, the narrow canals, are actually emptying into. And we also have wastewater outlets, which are part of more of the formal system, and the small sluice gate and the wastewater outlet. And then again, we also have things like manholes. And a lot of this, we were able to pick these sites and then also work with the Dhaka wastewater and sewage authority to help us with determining like what sites would be best. And so we worked every step of the way with the government of Bangladesh. This is just a summary slide. I'm just going to kind of go over it very quickly that describes how we collect the sample and then how we process it and then what detection methods we use for our work. So one of the initial ways we use to collect the sample is pictured all the way to the left top, which is called a bag-mediated filtration system. And you can see that Tanya is actually holding this large bag. And so you dunk that into the sewage and you get a 6-liter grab sample. And then pictured to the right of that, you can see that we're hanging that on a tripod, and then you actually filter it through a filter. Then you have to process that filter cartridge to elute the pathogens off of it. And that sample processing takes about $138. We have since converted to a new method where we're using nanotrap magnetic virus particles, pictured to the right top, where we only need about 40 ml of a grab sample. And I think the difference between the two methods in terms of time in the lab is about 4 hours versus I think 1 hour. So we've really improved the time of processing, and the cost is a lot less. It's about $15 per sample. So currently we're using the nanotrap magnetic virus particle method. Some of the detection assays that we are using is the CDC N1, N2 reverse transcriptase quantitative PCR assays to look for SARS-CoV-2. And we usually run those plate format PCR on the Bio-Rad Opus. And we also do Illumina sequencing for variables of concern and variables of interest. And we do that on the Illumina MiSeq or the Illumina NextSeq, pictured all the way to the right bottom. We also have developed some variables of concern, real-time PCR assays, and we usually run those again on the Bio-Rad Opus. We have also tried to develop digital PCR assays to try to get to the absolute quantitation of how much virus is present in a sample. And then the other method that we use to look at multiple pathogens in one go is called the TACMAN array card method. And we usually run those on the VIA 7 pictured in the center. Once we generate all this data, we really needed to find a good way to disseminate our lab data to the public health stakeholders. And we knew that we couldn't just report raw data out to the public stakeholders to make them understand what was going on in our study area. So I was really lucky to work with very talented fourth-year biomedical engineering undergrad students back in 2020 and 21. They were Aaron Whetstone and Lauren Hewlett and Claire Reagan, but I was their capstone mentor. And they were tasked with developing this dashboard that you see here, which displays not only the weekly sewage intensity, but also the clinical cases that were found in the wards. And so what you see here is that all our 51 sites are shown across the 5 study areas. And each one of those dots is our ES site that we're actually sampling from. And the intensity of how much is there changes depending on the color as well as the diameter of those circles. And what you see in the background are the wards, and you can see that the wards are also colored differently. So for example, taking this week here, you can see in the high income area, you see 0 cases being reported, but you're still seeing virus in the sewage. And so I encourage all of you to visit our website if you have time. So in terms of the work that we have done, we've actually prepared a manuscript that's in press, but looking at our overall data collapse from all of these 33 sites, this is what we see. The clinical data is shown in the light blue, and then the purple data is the environmental surveillance data. And what you see just generally is that there is a good overlap of the trends of going up and down, like in the disease surveillance. And what you also see, I think, initially is that environmental surveillance starts to trend upwards prior to when the clinical cases do. And the highest level of cross-correlation that we see is that the sewage data precedes the case data about 5 days. So it gives you about a week warning when things are trending upwards. And during the major waves of like Delta and the Beta waves, we actually saw that the ES preceded the cases by 1 to 2 weeks. And so you really see a use case where, you know, if you were doing this on a weekly basis, you can sort of, especially in the LMIC setting, you can actually like prepare maybe more clinical testing in areas where you're seeing the trend upwards to try to understand what's going on. A lot of this work was done by Isabel Blake out of Imperial College London, and Liz Rogowski and Stephanie Brenhofer, who were both at UVA at the time. Liz has now moved on to Emory, but just want to make sure to credit everyone that's been working on this stuff. And another thing that Stephanie has worked on is trying to see if we can use the sewage data and the clinical data to try to predict what's going on in the following week. And so she used the vector autoregressive moving average model, which is shown here. And what you see is, again, in the light blue is the actual clinical case data that we are getting. And then in purple is the predicted case data. And what you see is that it corresponds pretty well. And where it doesn't correspond well are times, if you look at the second Eid vacation, you do see a dip in the clinical cases because people are now outside of Dhaka and can't access a lot of the clinical testing. And so you see this like huge dip in the clinical cases, but the prediction model actually shows that it's going up. And so what we found out from looking at this model very carefully is that without very good clinical data, we're not going to be able to predict things very well. So that is what we found by trying to predict what's going on the following week. And now breaking up our data more on a ward level, you can see from left to right, it goes from low income to middle income. And once again, just a reminder that wards 2, 3, and 5 are low, 8, 9, and 10 are middle, 18 and 19 are the high income area. And so what you can see here right away is that you see Ward 19, there's a lot of clinical cases being reported, but when you look closely at the environmental signal, it's really no higher than any other wards. And so what that told us is, are we seeing the effects of actually rich people being able to afford testing versus not? And when we did that analysis, we did see that Ward 19 had about 70 to 120 times the number of tests per population than any other wards. And so you can really see where environmental surveillance actually is this unbiased look at how much virus is actually transmitting within the community without this type of bias towards whether you can get tested or not. And collapsing our wards into the low income and middle income and high income area, we also wanted to see, do things correspond with like population? And so you can see our low income area had the highest population, and then the middle income had in between, and then the high income had the lowest population. And so you would think if, in fact, the environmental surveillance transmission rates were about equal across all areas, cumulatively, you should see that the lowest income areas would have the highest burden versus the middle versus the high income. And what you do see here is, again, if you look at the high income area, the clinical cases are coming up really high. But if you really look closely at the sewage level, it's actually the lowest among the three, which we would predict, knowing that less people actually contribute to the sewage. And so in terms of where are we now? So this is sort of us doing everything from 2020. This is where we are currently, where you see very, very low levels of clinical cases are being reported, but still you see quite a high transmission within the sewage. And just like everywhere else in the world, I think people are really tired of COVID, and definitely people are not getting tested anymore. But then we're still having people with COVID. I just want to also summarize some of the work that we've done in terms of doing genomic surveillance for COVID. We had in total about 843 samples of clinical sequencing that was done by a nationwide consortium, and that's shown on the panel all the way to the top. And so in order for us to compare our genomic surveillance and wastewater, we also wanted to restrict ourselves to data that was just coming out of the Dhaka district. And so what you see in the next panel is the clinical cases, but the ones that were sequenced from patients in the Dhaka city. And then what you see in the next panel is the sewage sequencing data. I think we sampled about 263 samples. And what you see is that there's a good correlation between what we see in the clinical cases versus the environmental surveillance sample. And what's even more encouraging is that we see things like recombination of these pathogens actually in sewage, which are shown in the yellow and the black colors. And currently what we're trying to do is to do the same thing that we did for the overall correlation between clinical cases and the environmental surveillance. We're trying to understand if the wastewater genomic surveillance will give us some lead time. Are we able to see it before we start seeing in clinical cases, or is that not the case for genomic surveillance? So that's some of the analysis that we're working on. A lot of this work was performed by the three people pictured here: Supurn Fawat from UVA, Tony Raman, and Tanya Ferdosi from ICDDRB. To add to all this, we've received additional 3-year funding. And I think moving forward, we really believe that genomic surveillance for COVID is more informative than just doing SARS-CoV-2 surveillance. So I think that's the direction we're going to be moving forward for the next 3 years. One of the success stories of our current project have been working really closely with the public health stakeholders. So again, who is engaged? So IEDCR, which is like the CDC, the health ministry is also involved, the Dhaka Water and Sewage Authority, and also the local government, which is the Dhaka North City Corporation, Dhaka South City Corporation, the Department of Public Health Engineering, and also local funders. And I think it's really important when we engage in this type of implementation science that it is actually something that they are interested in so that they can take it up for the future. I think one of the things that we struggle with is moving it from the research space to something that's done regularly as part of the government work. And again, one of the interactions that was really important for us was that we communicated the results to the National COVID Task Force on a weekly basis. They also used our dashboard to make important decisions about lockdown or moving some resources for testing to those areas where they felt like the clinical case was lacking. And we also have these regular annual dissemination meetings that's pictured here with the government. And then we also have mass media, especially the news media, have been really interested, and they work with us to report some of the things that we're finding in our study. So just some conclusions is that we were able to implement this real-time environmental surveillance in multiple areas of Dhaka City, regardless of the fact that we have this informal sewage system. And the ES does provide early warning signs of increases in transmission of SARS-CoV-2 and can identify ongoing transmission in these areas where case surveillance is very limited. We also found that genomic surveillance can indeed be done in environmental surveillance, and we think that it's like an important part of the surveillance moving forward. And I think the SARS-CoV-2 dashboard is used by these public health officials as a complementary surveillance system. I think it's like a powerful message that it's actually being taken up and that they've bought into the use case for the ES. And we really think that as the clinical testing recedes, which is what's happening now, it's really important for us to do the surveillance on environmental samples so we can monitor the SARS-CoV-2 as different variants emerges and so forth. And our future studies will focus a little bit more on environmental surveillance for multi-pathogens. We can talk a little bit more about that in the next couple slides. But what is not known right now is, yes, you can find a whole bunch of multi-pathogens in environmental surveillance, but we don't know how that detection relates to clinical cases. And until you make that case that the environmental surveillance actually is correlated to clinical surveillance, it's not going to be very useful as a complementary surveillance system. So those are some of the questions we would love to answer in the new grant that we have for the next 3 years. But some of the multi-pathogen work that we've done in the past, we have looked at some clinical data against some of the environmental data. So what you see here in the top panel is the clinical diarrhea surveillance data that we had a study going between August 2014 and 2016. So you can see the seasonality of some of those other pathogens. And then what you see on the bottom is the actual ES data, the environmental surveillance data, and the seasonality. And unfortunately, these two data, they don't overlap. And we do know that depending on year to year, especially things like flu, it moves. And so we don't know if these other pathogens do move or not, but we just wanted to take a quick look and see if we see any good correlations. And what we do see is that for rotavirus and salmonella, we do see that the clinical and the environmental surveillance do seem to correlate, and that if you look closely at these pathogens, it's obvious that these are not contemporaneous samples, but recognizing that they're not, seasonality varies from year to year. We understand that as well, but these plots suggest the sewage sample predicts seasonal diarrhea attributable to rotavirus, salmonella, enterotoxigenic E. coli, and it's close for adeno 4041 and Shigella. So what we see from here, especially looking at rotavirus, for instance, the best correlation is 1 month prior. So what that means is that in environmental surveillance, you start to see things trending upward about a month in advance of the rotavirus clinical case peaks. And so again, so this, I think, happens for rotavirus and salmonella and not so much for the other pathogens, but maybe that means for rotavirus and salmonella, we can use ES, environmental surveillance, as a good complementary surveillance. Anyway, so a lot of all this multi-pathogen work, we're still in the middle of doing a lot of data analysis, and we do have contemporaneous sampling for both clinical and environmental surveillance for the last 3 years. So I hope we can maybe talk about some of that, and we'll have a little bit more clarity on which pathogens are good ones to follow in environmental surveillance in the months to come. Another cool modeling work that we've done is we use the generalized additive model to see if we can see long-term trends in detection, regardless of the pathogen. So what is shown here, this work was mostly done by Jillian Gold. She is an infectious disease modeler at the Bill and Melinda Gates Foundation. So what she's showing here is that there's a shared trend across different pathogens that shows that there's like a higher detection rates for pathogens just in general in January, April, and so forth. which is really counterintuitive to many of us infectious disease researchers, where we think of pathogens as being seasonal. This is kind of telling you, no, it may not be seasonality. It may be something else that is causing a pattern where we're seeing more detection, like in January and April and so forth. So the question again is, what is causing this pattern? And does this correlate to any known weather patterns?
Mami, I have a quick
Yes.
question. You
Yes.
did a lot of enteric pathogens, and usually
Yes.
monsoon is an important part of the story.
Absolutely.
So I don't remember where, at least in India, the monsoons are in July. Is Bangladesh similar, or has anything
It
really? I'm
is.
just surprised with this plot is the reason I asked.
Yes, I was a little bit surprised with this plot in particular, but we have looked at seasonality, and definitely seasonality affects things like rotavirus, the dry season versus the wet season. And we do see that across India and Pakistan as well. And what's really interesting is that the seasonality is a little bit shifted depending on where we're doing it in the Indian subcontinent. So that's also been an analysis that we've been looking at: rainfall, monsoon, dry season, and temperature, and so forth. I don't think I have any slides to show on this particular talk, but I'm happy to talk to people offline about some of the other analysis that we've done. Just a quick look after doing this modeling work, what we did see is for enteropathogenic E. coli, enterotoxigenic E. coli, C. difficile, Sabin 3, Shigella, and the vaccine-derived poliovirus. For some reason, they actually share this trend of being found more commonly at those peaks of January and April. And then the other pathogens either were significantly different than that pattern, or there were some pathogens where there was just like not enough detection for us to extract any data. But just kind of looking at 3 pathogens in particular, with looking at COVID time trends for 2 different targets, plus this sapovirus with the clinical sampling, we found this really interesting trend that there's a trend between sapovirus and SARS-CoV-2 being found peaking at the same time, which isn't something that we would have predicted, especially because SARS-CoV-2 doesn't seem to be weather related. But again, these are fun modeling things that Jillian has been working on. And what we don't understand is there another layer of variables that we need to look at that's causing these patterns? For SARS-CoV-2, E and N1, we would assume that they would trend together because that's just looking at a different part of the genome for the COVID virus. And so I think I'm at the end of my talk. I have a very large team working together with us. I'd like to give a shout out to Dr. Isabel Blake, who's a co-PI on this endeavor. She's out of Imperial College London. And my team here at UVA, Dr. Suporn Folwat in the center, Arian Whetstone to the left, and it's Stephanie Brenhofer to the right. And then my laboratory and field team in Bangladesh, there's just too many to name, but they worked so hard through the pandemic. Even during the lockdown, they were out there collecting samples and processing them. So we owe them a lot. Dr. Rashtul Haq, shown in the center of the laboratory picture, is the other PI at ICDDRB. And also, there are also a whole bunch of other people that we worked with on our project that I'd like to thank. They're listed here on this slide. Thank you so much for your time.
Thank you. Very nice talk, Mami. I'm going to hand it over to Golda for moderating the question and answer sessions. Okay. I have some questions, but I'll let others ask first.
Hi, that was a fascinating talk, and it seems like an awful lot of work that you guys have been doing. I was curious about some of the time series that you showed. So
Yes.
There were some negative correlations that looked really significant. And do you have any idea what's going on there?
So I think due to the fact that the pathogens were not, the clinical surveillance and the environmental surveillance weren't contemporaneous, we've decided to maybe dive into that once we have the contemporaneous data, which we're working on right now. We did notice that there was a lot of negative correlation. And I think we decided that it's probably better that we're looking at clinical data and environmental data that's sampled at the same time. So more to come.
Yeah, that would help. Also on the ARMA model,
Yes,
it looked as though it was forecasting really well, but it was the case reports that were forecasting the sewage really well.
this one, right?
Yeah, this one. The green curve is the case data,
Yes.
and the predictions, like at the beginning of the curve, it's a really good match, but predictions are about a week or so after the case data.
Correct. And so I think, so we don't use this Varma model anymore. I think this model is only as good as your clinical data because it takes into account of both your clinical data 1 week prior and the environmental surveillance data. And
Okay.
again, we have noticed, just as you pointed out, that the predicted case data, there's a week lag and that it wasn't good enough for us. And so that's one of the reasons why I think we no longer use the Varma model to do the prediction for the following week, and that we need to build a better model. And now that with the clinical cases being so underreported, it's impossible for us to run this model anymore and use it to predict what's going to happen the following week.
And one last thing, if I could, is
yes, of course.
You had the number of people contributing at each of the observation stations. Did you look at normalizing the counts by the number of people?
Yes, we have done that as well. We do normalize against how much virus is there and also normalize against the catchment area itself. We've also done some analysis on how much people need to be contributing to make the best, I guess, where is that correlation best? And so that's another thing that we've worked on is how many people need to be contributing to really give us a better idea of how much is there. And so we have done both of those, but I think what we found was that around 20,000 to about 40,000 is around the best, I guess, catchment population to get. We need that many people contributing in order for the environmental surveillance to be most informative.
Thank you.
Okay.
Thanks for the great talk. My question was about the variability in viral shedding, I guess, due to severity or the point in the infection, and whether if in looking at clinical data or whether wastewater is going to be a good early indicator of maybe only severe cases going forward, given that maybe earlier on there was a higher percentage of severe cases, and whether you think there's, in terms of clinical data, I suppose in Bangladesh, I guess there's a primary source of case positives. And as you said, whether somebody has to go to the clinic or not may have something to do with the severity of the infection, which in turn has something to do with whether you detect it in wastewater.
Yeah, so in wastewater, it's like a big picture, right? It's like a drone that's like high up looking at the infection. It's going to be really hard to tell, I think. It's going to catch both asymptomatic and symptomatic shedders. And how much we shed also depends on your vaccine history and so forth. And there's not a lot of work done, at least in the SARS-CoV-2 space, whether a person that's like not vaccinated, has never had it, how much virus shedding is there, and so forth. A lot of this work has been done. So I work in the polio space, and we've studied a lot of the stool shedding after what the first vaccination, second vaccination, and the type of different vaccinations and so forth. So it's much easier in the polio space for us to predict how many people may have polio upstream from your environmental site. But I think for SARS-CoV-2, not enough work has been done. So it's really going to be hard for us to say during this peak, we think with this estimated severity, we can say that 100 people were contributing to that environmental surveillance site. I think that kind of epi modeling is going to be super hard to do, I think, at least with the information that we have at hand now, versus things like polio, where people have really studied stool shedding of poliovirus, depending on your vaccine status or where you live and so forth. And so I guess the short answer to it is I think this is the best that we can do. And I don't think we're going to get to the point where we're going to be able to predict exactly how many people are shedding, and the severity of disease. Just looking at this would be really hard to predict.
Okay, great. Thanks.
Yeah.
Thank you for the nice presentation. I'm from Bangladesh, so it was very interesting
Oh, no
to see.
way. Oh, that's great.
And I have lived in Dhaka for quite a while, since my early
Oh,
childhood.
wonderful. I've been working there for 15 years.
Yeah, that's really great to know. And I had a question. It was very fascinating to see that environmental surveillance sample, how it correlated so well with the clinical case data. But with regards to COVID, we have some perceptions. So the thing is, when back in 2020, when it all started, people were getting scared, and when the first cases were reported officially. But what was officially reported by IEDCR and the media, and what was the people's thought, there is a discrepancy there. We thought, I mean, most people in Bangladesh thought that the cases were way too higher than what was actually being reported. Now, the causes could be different. You already mentioned that some people were not getting tested. There could be also political causes as well. So I was wondering, when you are trying to correlate that data with environmental surveillance, did you have to do any corrections for that, or did you have faced any problems with regards to that?
Absolutely. I think you can see at the beginning of the pandemic, especially, the correlation is like not as strong because people were not getting tested and we didn't know how many people were really sick. And that's like one of the benefits of looking at environmental surveillance, is that it's unbiased, right? It doesn't matter whether you're tested or not, as long as you're contributing. And if you're sick, asymptomatic or symptomatic, you're going to be shedding, right? So what we showed was, by April, we're seeing really, really high levels of virus in the sewage, but there were no clinical, I think, data until almost July 2020. And so we didn't have any clinical cases prior to that. They just didn't have enough compiled, and there was not enough testing being done. So we were aware that it was going to be a harder correlation earlier on, when there was just sporadic reporting. And so I think if we look back on these slides, I think you can see that, yeah, do you see where this clinical surveillance was established from July 2020? So
Yes.
prior to that, you saw little bits of reporting, but we knew that that level of reporting was really an underestimate. So just another reason why maybe doing both clinical and environmental surveillance will give you that extra layer of data, whether there's underreporting or not.
Thank you. I had a small second question related to
Yeah,
that.
of
So
course.
if you, in case, I mean, there can be many countries where you have this issue with underreporting.
Yes.
That is the case. And if you have this environmental surveillance data, is it possible to correctly, or let's say with a reasonable accuracy, estimate the number of cases, actual number of cases from the surveillance data? If you know, let's say in your case, if you know that this is the exact number of households or people who contributed to that much sewage water, what you have sampled, is it possible to reach a reasonable amount of accuracy from that sample?
I mean, theoretically, yes, that's possible, but in our study, it's probably never going to be possible. There's just like not enough testing, especially in like the low income area, to be able to do that modeling and be super accurate. I think there were a lot of attempts in high income countries, even here at UVA, to do building level testing where we knew how many people were sick inside that building, and then to do the wastewater surveillance to understand like how much virus you would find. And I think there's a lot of people, especially in the high income area, working on that. But you have to go on a building level or like very, very small catchment where you know exactly how many people are sick to build that model.
Okay.
And at least like the way we're doing the surveillance, right? It's like we're almost surveilling close to 1 million people in our study area. And with this many underreporting of clinical cases, that's probably not going to be a model that we're going to be able to build, at least from our data.
Okay. Yeah. Thank you.
Thank you so much for this nice longitudinal view over the 3 years. It spans a lot of domains that we're working on. So one thing that I was curious about was this mapping out of the sewage sites that you showed in the beginning. I'm curious about, maybe you can talk more about like the site selection process, because I'm wondering if there is any bias towards whether you're immediately next to, say, a hospital versus like a factory. And I mean, related question to that, if you want to really get a good sample, like, I mean, where there's some kind of optimization done, and what Tanvir was asking kind of motivated another question, which is like, were there any kind of pushback from the community or local regions for sampling from that neighborhood?
No, I mean, great question. Yes, there are some site characteristic minimum requirements that we have, like no industry should be like contributing right away. And we definitely do not sample close to a hospital, like a Dhaka Medical College is like a huge hospital, and we don't have a site where that wastewater is directly coming into, because it's not a fair assessment, because that within just that hospital, you're going to have tons of patients inside. And there are minimum requirements. So we take physiochemical properties for every single time that we get a sample. We make sure that the pH is around 7. The total dissolved solids also have to be quite high. There's a range, but I think the minimum is about 400. I don't remember the exact units, but these virus particles actually stick to dissolved solids. And so if there's no dissolved solids, it's a pretty clear sample. You're probably not going to recover a lot of SARS-CoV-2. And so things like that. And then we also stay away from sites that are affected by flooding or by rain. So what we do is we go in and overpick too many sites, and then we cut things down. And we also have ones that are nested, because we want to understand, is the 600,000 too many people? Is it causing PCR inhibition? So we can't really correlate the cases with the environmental surveillance. So we have things that are nested like 600,000 and then 300,000, and so forth. So we are trying to do that analysis. Where is the sweet spot, for SARS-CoV-2? And for polio, we know that number is around 150,000 to 200,000 people need to be contributing to have an effective environmental surveillance for polio. So it's still a work in progress, but your question is so important. And in Bangladesh, we did not get any pushback from the government. I've been working there for many years. And like I said, we had an environmental surveillance study already up and running. So when SARS-CoV-2 came, they really welcomed us and said, if you can help us in any way to give us more information, that's wonderful. So that's what happened there. But I have another study in Pakistan where it took me 12 months to just get an okay from the government to sample from water, because people would be suspicious, they said, that we were dumping things into their water or doing something to their water. So I think it's like very culturally sensitive. I think the Pakistan government works a little bit differently. So it took us a while to get all those approvals. We also had a study in India. I mean, we worked with somebody who is Cherry King, is like really high up and is well known in India, and we were working under her, so we were able to get government approvals quite readily. But in other parts of India where I've worked, like in Trichy and Coimbatore, it took us a couple months to get those approvals in India. So I think it just depends on where you are. But I think that building that trust, and then definitely working really closely with the people, I actually live in Bangladesh for about 6 months of the year. So it's not like I just go every now and then. So all the government meetings, I usually attend them. So they know me personally. I think that helps. Yeah.
Thank you so much. Yeah.
So I have a couple of different questions. One of them, and I'm just going to go through all of them at once, and then I'll sign off. So you sort of alluded to this. So the hydrology of the sample areas like Bangladesh and Delhi would be really different, right? I mean, just the hydrology. And so in the rain, you sort of got to this, you don't sample when it's raining a lot. But I just wondered how much water table variation versus, the viral load in the wastewater variation can be decorrelated. And also, especially because I think population behavior changes in the rainy season and dry season, maybe, so that if there's any hope for maybe modeling, like behavioral modeling or hydrological modeling or something to help maybe pick this apart a little bit would be valuable. That's my first question. The second question, you made a passing comment on viral a genomic recombination. And I'd like to hear a little bit more about what you meant and what you just said. And also, if you're interested in, alerts on mutations generally, right? I mean, like if there's technology to alert on evidence for mutations.
Yeah, thank you for your question. I don't know if I remember all of them. I'm so sorry. I'm still sick. So the first question about impact of monsoons and rain. So we did look at the weather patterns, and we did some analysis on fecal indicator organisms, which are organisms that's always found in wastewater. And then we try to do a correlation to see if there was a dilution factor or anything going on with those, indicator organisms during high rain or low rain season. And what we found was at least the sites that we had selected were not impacted by monsoons. And so we were able to collect from all of our sites except for one, which was near the river. And so what we noticed was during the monsoons, the river water would get high and then would come and not just dilute, but make our sample no longer isolated sample from coming in from these areas, right? Because you have a pushback from the river. So you have a mixing of that sample from the river water as well as the actual wastewater coming in. And so we noticed that. And I think what we decided to do was get rid of that site. And we had to go a little bit more upstream where it wasn't impacted by this like flooding. And we determined that by looking at the rainfall data and doing some analysis on the fecal indicator organisms, whether it became diluted over that the rainy period. So that is one thing that we did. And also, I think your second question was about the recombinant. What we do know of viruses is that they recombine. There are recombinants, right, that are happening, and we should see that in wastewater, right? You have a whole bunch of like SARS-CoV-2 and other coronaviruses, and they should be kind of mixing and then recombining, and you don't usually see that in clinical cases. So that was something that we had hoped to see because we know that happens in the environment, but we don't do any risk assessment per se, whether these recombinants then go to infect people and then are introduced as a variants of interest or VOCs. What we do know from some of the studies that are done, that there is really no risk of like catching SARS-CoV-2 from wastewater. It seems to be that's the general trend that we are seeing because no one's able to culture live SARS-CoV-2 out of wastewater. So that's what I know. I don't know a lot about the actual recombination, which recombination happens more frequently and so forth. I probably would have to ask some of my friends who are in virology about coronavirus recombination, but I don't know a lot about that. So I might have to put you together with some of my collaborators.
Thank you so much.
Yeah.
The talk is really, really super. Your work. Thanks.
Thank you so much.
I will keep my comments brief and I can talk to Mami separately. But Mami, first of all, let me thank you again for a wonderful talk.
Thank
I
you.
think the questions should have given you a good sense of the level of interest here. So a couple of things. One, I will maybe arrange a meeting, since you're in town.
Yes.
Come here in the next couple of weeks. I know.
That would be lovely.
You might leave back to Bangladesh again. So we'll try to do it sooner. I think you should meet others here and maybe have a longer conversation. We have an ongoing project with VDH. We're also part of the Pathogens Genomic Center of Excellence that you might have heard about.
Yes.
Where Amy, whom you know very well, is part of it. So perhaps more to discuss as you come here. I'll leave you with one question. Don't need to answer it right now.
Okay.
But others might want to hear. But I want to take Srini's question to heart and understand what it takes to do a good design of placement of these systems and effectively move them around as well. I think my bigger question is, you did an amazing level of assays. I mean, you covered so many diseases. Can you give us a sense for how much it costs effectively to do this? Because if we want to really do a very good job, it's doing surveillance in our state. Fundamentally, that's what it comes down to, the cost. And I'm trying to get a sense of the cost. And maybe that's what we learned. You can tell us that, and then we can.
Sure. So in terms of like cost for SARS-CoV-2 environmental surveillance for the last 3 years in Bangladesh, that was about a $2.6 million endeavor. And again, personnel cost, of course, is like a lot less in Bangladesh. I have a really large team. And so if you were to do this in the United States, the cost probably of personnel costs would probably be much higher. And in terms of the multi-pathogen work that we do in Pakistan, which is also a 3-year study, it's around a $6 million cost to do all these multi-pathogen things and then pay for people. So that's sort of like the ballpark that I have.
6 million per year?
6 million, or no, for the 3-year period.
So it looks like for a couple of $1 million a year. And does it scale linearly with every extra pathogen? I'm trying to understand what it would cost.
No, actually adding extra pathogen doesn't like make it that much more.
Right,
Because you do one collection, one extraction, one nucleic extraction, and it's the matter, for SARS-CoV-2, we just do one PCR plate versus do a TAC card with 40 to 60 pathogens in one go. So that's the difference. And for that assay, it's $62 per sample to do all those multi-pathogen versus doing SARS-CoV-2, a three-plex PCR is about $7-8. So that's where the difference comes from. But you do have to also buy instrumentation, and that's usually not cheap. A TAC machine plus a centrifuge is about $100,000 versus a regular PCR machine is, $23,000. So it also depends on equipment. Genomic surveillance, again, I think is really the future. Is quite expensive. The cost has come down. For the genomic surveillance, we've been really lucky. We've partnered with Illumina, and they actually donated all of their kits, which adds for our particular study added up to about $200,000 worth of kits. So we got all that for free. And there was the NextSeq and the MySeq are both, again, sequencers that cost, $100,000 and things. And so not cheap, but once the instruments are in place, it's not that much more to do the multi-pathogen thing. And I think the answer, the thing that we're trying to answer is by looking at these multi-pathogens, we want to then narrow down to pathogens that we know we can do surveillance, and it's informative in terms of like its correlation with clinical cases. So once you're down to that, I think then you can develop like several PCR assays to do just those pathogens, which would save you a lot of money. But at least here in Virginia, at least with Marcia Deegan that I've spoken with at VDH, they're very interested in doing all of this. And, I helped them earlier on to do the SARS-CoV-2 ES stuff, and I'm happy to help them out. But I think in Virginia, it's probably going to be a much shorter list than a lot of these enteric pathogens. We don't need to look at rota. We have vaccines for that here and so forth. So there are probably a lot of these pathogens that I look for in LMICs that are not relevant in high income countries.
Right. That's a good answer. So I get a sense, because I think that this is such an important technology and the cost can be driven down more. For a state like Virginia. I think it's not such a huge cost to get a good sense of the state of diseases in the state. At least I think so, but maybe I
agree.
Yeah. So okay, thank you so much, Mami. Thanks again.
Thank you.
Wonderful talk, and I will get back to you with a
Yes. And
Yeah.
also, if anybody else is interested to come to Bangladesh anytime, I'm happy to host and have you come and visit our sites. People come all the time, so just let me know.
We'll do that. In fact, some of our students who are from Bangladesh and postdoctoral fellows,
That's great.
they might want to work with you just because I think I know that they care, and the way to contribute back to their country would be something that
Oh, I
sure
would
they will
love
be willing
that.
to. So we'll try to do that.
Yeah, my grad student's also from Bangladesh. She was actually working on my team, and she's here getting her PhD in the ESE. And coming next fall, I'll also have another Bangladeshi PhD student actually from my team joining my lab. And so, yeah, always welcome, not just Bangladeshis, but anyone who's interested. Please let me know, and would love to work with any of you.
Great. Thanks so much,
Yeah,
Mami.
thank
Thanks
you.
again.
Thanks
Bye.
everyone for joining
Thanks,
us.
Olga. Bye.
Thanks.